So just to start off, thank you for the introduction, Dr. Okello. Dr. Okello is our president. As we know, when an organ is transplanted into a recipient, automatically the immune system is set into action. There's a response, and these responses to foreign tissues. So initially, when you put in the transplant, the innate response is set in. The innate response is within the first 4 hours, the macrophages are mobilized, the dendritic cells, natural killer cells, and many other types of cells. Now, these ones are also called the antigen-presenting cells. So they move with these antigens from the donor and go to the lymph nodes and activate the T-cell mediated response and the antibody-mediated response. Specifically, we are going to talk about antibody-mediated response. When, as I said, innate cells are activated, they go to the lymph nodes. In the lymph nodes, they set up 2 responses, which we call the delayed responses. We have the antibody-mediated response and then the T-cell mediated response. The antibody-mediated response is by the big lymphocytes. And the antibodies, when they are released, they act in 4 main methods. One, they activate the complement system. The complement system is activated. And once the complement system is activated, this complement system attacks the endothelium of the vessels in the graft. So that's one way the antibody-mediated response works. The second type is when they activate other cells. They activate macrophages, they activate neutrophils, and these neutrophils and macrophages go and attack the endothelium in the graft. The third type is that the antibodies themselves can effectively attack the endothelium directly. And in so doing, they cause injury as themselves. They don't need to activate anything. And lastly, the antibody response also activates the coagulation cascade. So these 4 methods is how the antibody-mediated response is activated. And most of the antibody-mediated response is against the endothelial cells in the graft. Now, specifically, it has been found that of all the 4 ways in which the antibody-mediated response works on the graft, the major one is the direct attack. The antibodies directly attack the endothelium. For one reason, those are the first cells they see. When the antibodies are released, the first cells of the graft they come into contact with are the endothelial cells in the graft. And in so doing, they cause vasculopathies. And the vasculopathies is almost like causing ischemia in the graft. So antibody-mediated response causes early graft rejection. If it is not addressed, the graft is going to be rejected as early as possible. So in conclusion, it has been found that in kidney, heart, and lung transplant, this antibody-mediated antibody-mediated response occurs in 10 to 15% of the people who have been grafted. And it is a major cause of early allograft losses. And also, once it is set in, even if you control it, it has already caused some damage. So the survival of the graft is compromised if the antibody-mediated response sets in. The most important thing is not even to allow it to happen in the first place. And this response is less common in the liver transplants. It's more common in the other types of transplants. Now, when this response sets in, or to prevent it from happening, those are the drugs we use: rituximab, eculizumab, IV, IG, plasmapheresis. And as you can see, some of these drugs, we don't use them anywhere in liver transplant because antibody-mediated response is less in liver. We have our own drugs, which we always use. These are not some of them, but you will see that they are commonly used in other types of transplants. Now, when we go to the T-cell mediated response, this is now when the antigen-presenting cells, those are the lymphocytes, leave the graft, leave the graft, they go to the draining lymph nodes in the host, and in so doing, they activate the T lymphocytes into CD4 plus and CD4 8 plus. Now, these lymphocytes are the ones which end up causing more cascade and more damage, as we shall see. And you will see that in liver transplant, all our immunosuppression is basically directed to T-cell mediated response because this is a major response in our transplants of liver than the antibody-mediated one. Now, as I was saying, we have more T-cell mediated response than antibody-mediated response. And in so doing, in liver transplant, we end up needing less amount of suppression, either at induction or at maintenance, because we don't have the burden of antibody-mediated response. We have a bigger burden of T-cell mediated response. And also, because of that, the liver, there is less incidence of chronic immune-mediated injury to the liver, despite the low suppression doses of our drugs. In the liver, we don't need a lot of drugs, but in other transplants, you'll see that you need a lot of drugs because somehow the immune cells of the host always dodge the system, always dodge the immune suppression. So why is that? We know that in liver, naturally, in any other person, me or anyone, the liver has a balance, just to strike a balance between tolerance and immunity. Naturally, that's what it does. So before even the liver from the donor is transplanted, the liver is always in insult from continuous exposure of antigens coming through the GIT, the food, the medicines, the byproducts of bacteria of the GIT, all those things go through the liver. So the liver over time gets, what can we say, sensitized. It is now not overreacting. It doesn't box anything. It doesn't throw stones at every dog that barks. So it is kind of getting tolerant, it gets tolerance. So in so doing, it can also be used, it can tolerate the immune response from the host without causing a lot of damage. So the liver has that advantage that by the time you transplant it, it is already tolerating these antigenic responses. It has seen it all in English. That's what we could say. So that's why it doesn't need a lot of drugs to maintain it. So and that's what we call liver tolerance, the liver tolerance. And one way you see that this liver tolerance is that naturally, instead of having macrophages, in the liver we have Kupffer cells. Kupffer cells are modified macrophages. The dendritic cells in the liver are different from the dendritic cells in other parts of the body, and their response to antigen or to attacks from the immune system are different. The liver sinusoidal cells also respond differently, like I've put on the other side on the left. What does that mean? Instead of increasing inflammatory response when it is attacked, instead it causes anti-inflammatory response. It can reduce the cytotoxic C cells, apoptosis. It stimulates the regulatory T cells. It does not produce interleukin-2 when attacked by outside forces. So this is all tolerance when it's not even yet transplanted. This is tolerance developed over years when the liver is in someone. So these modifications make the liver more stronger. And also that means it doesn't need more drugs to suppress it when it is in the host. But sometimes tolerance per se is not foolproof. Tolerance per se is not foolproof. That's why we need to suppress, immunosuppress, even when you have what? Transplanted the liver. Tolerance has also limitations. And one of the biggest problems is the ischemic reperfusion injuries. When you're transplanting this liver, it affects, it kind of reduces the tolerance of that liver. So if we can minimize the ischemic and the reperfusion injuries, we also maintain the tolerance of the liver, so we shall not need a lot of immunosuppression after transplanting it. Now, in the liver per se, to even make we know the antibody-mediated response is less already, but even to make it much more less from happening, we need to minimize ischemia time during the transplant. We need to minimize reperfusion injuries, minimize cross-transplantation. Cross-transplantation means that the donor and the recipient should be as similar as possible. As similar as possible. The more similar they are, the less antibody-mediated response you will set up. And also we minimize the use of fatty liver. Why? Because when you have a fatty liver, that liver is not tolerant. It has started inflammatory, what we call non-alcoholic steatohepatitis. So there's all the inflammation. So the Kupffer cells are not behaving like they're supposed to. Instead, they are behaving like regular macrophages. So a fatty liver is already a compromised liver. It's no longer tolerating insult. So if you transplant a fatty liver, you are most likely going to fall into these antibody-mediated responses. So to prevent that, don't transplant a fatty liver. So now we go to immune suppressing the T cell response. And this is basically the gist of today's CME. And everything it can be explained on this image. I think you are seeing it well. And I'll just give some briefs in the next pages. As you can see, this is the antigen presenting cell. These are macrophages, leukocytes, dendritic cells. They present the antigen, which is some tissue from the donor liver. They present it to the T cell. And in so doing, one of the things it stimulates is the calcineurin system. The calcineurin system finally ends up leading to secretion of more interleukin-2. And this interleukin-2 is the one which is really the this is the one which causes the most T cell mediated response, because it leads to proliferation of T cells, B cells, and also mobilizing more. Basically, it persists, it causes a cascade, which is kind of vicious. So these drugs try to prevent secretion of what? Production and secretion of interleukin-2 through the calcineurin system. So this type of drugs which do that, which prevent through this, are called calcineurin inhibitors. They just prevent production of interleukin-2 through inhibiting calcineurin. And we have two examples, cyclosporin and tacrolimus. I don't know whether you see, does this thing, is it seen on, do you see my cursor? Do you see the cursor? Eh? You don't see the cursor, eh?
Yes, we do.
Oh, sorry. Okay, but you see on your left, calcineurin inhibitors will inhibit calcineurin. Is there any cursor we can use on is there where we do a cursor?
We are able to see your cursor, doctor.
Oh, yes, thank you. You're seeing it now? Okay. So this calcineurin system is one of the ways interleukin-2 is produced to increase the interleukin. The interleukin-2 is a stimulant. It stimulates more production of T cells and the B cells. And the drugs which work on this system are called calcineurin inhibitors, and some of them are called cyclosporin and tacrolimus. In liver transplant, these ones you will hear them all the time. The other place where inhibition occurs is this system here. You see corticosteroids? Corticosteroids also inhibit production of interleukin-2, but through a different pathway. So the corticosteroids will also inhibit production of interleukin-2, but through a different pathway. Then we have what we call the antimetabolites. We have azathioprine and mycophenolate. These ones will prevent DNA synthesis. They prevent DNA synthesis. These ones, the antimetabolites, they are all part of the drugs we use in liver transplant immunosuppression. Then we have the mTOR inhibitors. The mTOR inhibitors inhibit the rifamycin molecule. Now, this one, the way it works is that it doesn't really affect the interleukin-2 when it is released and it's going to attach to other cells to replicate. Instead, it prevents replication through preventing DNA synthesis. So even if the interleukin-2 is released, if you're using mTOR inhibitors, you prevent the interleukin-2 from acting on the other cell to replicate by interfering with this one. And lastly, we have these other non-specific ones, like the anti-thymocyte globulins and the basilicizumab. These ones work mostly, as we shall see, they are basically induction drugs. It's called induction drugs. They work directly as if they are antibodies because they are globulins. So with this in mind, we can now go to this. And also, this, all these drugs I'm talking about, they have a history. The first drugs they discovered were immunosuppressants were discovered were steroids, followed by azathioprine. This led to successful transplantation, but not reliable. And then we came in with the cyclosporine, mycophenolate, tacrolimus. Now we even have everolimus. These are the most modern. This is the progress of discovery of immunosuppressants to liver transplant. Tacrolimus is basically an antibiotic. It's a macrolide. So these drugs, as we talk about them, some of them have a double. They work as antibiotics and also as immunosuppressant. It is preferred to cyclosporine. Remember, these are calcineurin inhibitors because one, you require a less dose to get the same result. You get better patient survival using them. They give you, the tacrolimus will give you less nephrotoxicity compared to cyclosporine. So tacrolimus is kind of standard. As we are saying, it is the backbone of our immune suppression in liver transplant. It's kind of used in almost all of them, apart from few, as we shall see, where an alternative is given. And it can be used both in early, late phase, and also maintenance. Now, corticosteroids are almost nearly used in all patients. They are non-specific. They are mostly used in immediate and early post-op transplant period because of their side effects. So because they have a lot of side effects, you don't want to use them for long. You use them as much as you need them, and if there's an alternative, you switch. So corticosteroids are used, but you don't use them forever if you have alternatives. But in induction and early immunosuppression, they're like a must. Most people have those protocols where corticosteroids are used. Okay. As we saw the antimetabolites, we saw them, mycophenolate and azathioprine. Mycophenolate is preferred to azathioprine for the same reasons. Mycophenolate has less side effects, but mycophenolate cannot be used as monotherapy. Most times, if it is used as monotherapy, there will be rejection. The only time it is used as monotherapy in late phase maintenance is if people have very, very poor renal disease. They have very severe renal disease. If they have very severe renal disease and you can't use the calcineurin inhibitors, you may be forced to use what? A monotherapy of an antimetabolite. But antimetabolites are always core medication. They are supportive medication. Yeah, and also there are always alternatives to corticosteroids. Like I told you, when corticosteroids are causing a lot of side effects, the alternative can be mycophenolate. There are studies, there's a study I came across where the combination in the early phase can either be a calcineurin inhibitor and a corticosteroid, or a calcineurin inhibitor and an antimetabolite, like this one. And these ones, these are the new ones, the mTOR inhibitors. These are new. They are new for one reason. They were discovered that these can replace the role of calcineurin inhibitors, especially if the indication for the transplant was HCC. Because calcineurin inhibitors they have been found to have a likelihood of initiating malignancy, especially HCC. Yet when you are using the mTOR inhibitors, there is a way they prevent recurrence of what? Of tumors. So if the purpose of transplant was HCC, this can be used as a what? An alternative to calcineurin inhibitors. Now, the induction medication, as I told you, these induction medication, there are two. We have what we call the non-lymphocyte depleting and the lymphocyte depleting. Induction is basically the day zero of immunosuppression. They are not used beyond that. So this is the study which I saw. And in this study here, they realized that if you don't use induction, you are most likely going to use a triple therapy in your early immunosuppression. Yet, if you use the induction, you may even find yourself, basically induction, if you use no induction, you'll find yourself using a triple therapy, of which a corticosteroid is a must. And even if you say, I'm not going to use the triple therapy and use dual therapy, still a corticosteroid is a must. But if you use induction, you will find that you don't need corticosteroid therapy because you may use dual therapy where you have only a calcineurin inhibitor and an antimetabolite. So in so doing, if you use induction in your, and this is debatable, this is still debatable. Some schools of thought say no need of induction. Other schools are saying everything should be what? Induced. There's still a debate. And this was one of the studies which showed that if you use induction, you may not use corticosteroids in your early phase immunosuppression. So in conclusion, immunosuppression therapy must be individualized. Every patient is individualized, but in the confines of the transplant protocol. Each hospital has its own transplant protocol. You individualize, but you don't go outside. You don't go outside. You individualize according to the protocols which you have already agreed upon. 2, consider long-term side effects of drugs, especially calcineurin inhibitors and steroids, when you're planning the immunosuppression. You have to consider the long-term side effects in your plan. 2, 3, to induce or not to. Induction means hit the host with the drugs which destroy the lymphocytes which he has already. You know, that's what induction means. Before you take the graft into the host, first destroy all the lymphocytes which are there. So to induce or not to induce is still debatable. Combination treatments are preferred in the early phase, but remember in liver, by the time you do late phase, you're on monotherapy. Monotherapy using calcineurin inhibitors is preferred choice for late phase what? Immunosuppression. Cross-transplant is more tolerated in the liver because of tolerance. Cross-transplant means because there's cross-transplant, we have a bigger donor pool for where to get donors because we can take as many heterogeneous livers as possible. And lastly, surgery plays a very big role in the success of allografts through reducing ischemia time and reperfusion injuries. Basically, it is in the liver where we find that the surgical process is much more demanding than the medical post-transplant. Yet in the kidney, it is the reverse. The surgical process is kind of smooth. but the post-transplant management is much more complex. Lastly, patient post-transplant are managed as if they are chronic disease patients. What does that mean? You should already have a plan to follow up these patients for their lifetime. The good thing in the liver, this is less demanding. And if you're in a low volume transplant center, the transplant surgeons can do their follow-up themselves. You don't need a hepatologist to do that. Compared to the renal and the heart, where because of the complexity of the immunosuppression, you are forced to have either a cardiologist or a nephrologist, despite the volumes of transplants we are doing. And lastly, liver tolerance, natural liver tolerance leads to the need for low doses of immunosuppression, and hence less side effects in the patient, and hence better tolerance, better adherence. Thank you.
Thank you very much, Dr. Vianney, for that enlightening presentation. We shall reserve the questions at the end, and if you have any questions, you can post them on the chat. We shall take note of them, and Dr. Vianney will be around to answer. Let's give a chance to our international guest, Dr. Amey-India, who is from Mumbai, Apollo Hospitals. He has sacrificed his time to share his knowledge and experience with us. He's a very wonderful mentor. We're in Medanta together. He was a senior fellow when I was in Medanta. And now he's a consultant and a transplant hepatologist at Apollo Hospitals, now in Mumbai. Dr. Amey, you're welcome to give us your talk.
Thank you. Thank you, Dr. Michael. Thank you.
We can't hear you.
Can you hear me? I think I can see my microphone moving. Can you hear me?
Yes.
Yes, continue.
Right. Thank you, Dr. Michael. It was a pleasure working with you in Medanta. It was way back in 2017. And I'm glad to see you in that position there in Uganda. And let us begin with a talk. I'd like to share my screen.
First exit.
All right. Yeah. Can you see my screen? Can you see the screen? Can you see my screen?
Yes, we can see your screen.
Great. I will just make it PowerPoint now. Can you see it?
Yes, we can see it. PowerPoint. Proceed.
Fantastic. All right. So thank you so much, SUGES, for inviting me to give this talk. The entire idea of this talk is to talk more is in the form of a hepatologist, where we look at long-term management of patients who receive a liver transplant. The short-term management is more of a liver intensivist job as well as a surgical job of the surgeons. So I will just have a couple of slides for that, but I'll more concentrate on how do we manage these liver transplant patients when they come to you for follow-up on a long-term basis. So with that, Dr. Vinay has made my job easy by talking about immunosuppression upfront. So let us begin with this. So this would be the outline of my talk. We'll first talk about the unmet needs after liver transplant. Can we do a better job? We'll look at post-transplant metabolic syndrome, which includes a gamut of certain problems like obesity, cardiovascular disease, diabetes, dyslipidemia, hypertension, and the management for the same. We look at chronic kidney disease, the causes of chronic kidney disease post-transplant, early identification of these patients and how do we manage them. We'll have a couple of slides about de novo malignancy and recurrence of hepatocellular carcinoma if that was the indication for transplant. Then we'll have a very few short slides about how do we manage bone health, how do we manage rejection, how do we manage patients, especially female patients who have a liver transplant and who would eventually want to become pregnant. How do we use contraception for them? Look at some immunization protocols for patients who receive a liver transplant. The most important thing to know is about the immunosuppressive drugs, their interactions, their adverse events, which my previous speaker has already spoken a bit about. We look at recurrence of disease, why the patient was transplanted, and what is the chance that he might have the disease again. Then we look about certain good health instructions, and then we'll have a conclusion. And I'll have a couple of slides beyond that about the acute problems that we see post-transplant. Now, this is kind of a longish presentation, so if you want me to stop anywhere, if you're short of time, just let me know. So, can we do better? What was just 34% in 1985, the 1 year survival has gone up to way up to 86 to 90% over the last few decades. But still, we can do a better job. Can we go up to 90? Can we go up to 95% for in terms of 1 year transplant, post-transplant survival? And that is the key in managing patients immediately post-transplant as well as in the long term. So the outcomes of transplant have markedly improved over the last 3 decades, and predominantly why this has happened is because management of transplantation has become better. There is more better selection and optimization of candidates. The donor selection, the organ procurement has become better, organ preservation has become better. Post-operative care is now state of art. We have newer and better drugs in terms of immunosuppression, and we now can recognize recurrence of disease quickly and treat complications and comorbidities in a better fashion. And that has improved the post-transplant survival. But can we still do better? That's the question. So we all know that the major cause of mortality in the long run are non-immunological causes like cardiovascular diseases, de novo malignancy, chronic kidney disease, and recurrence of primary disease. There are certain other factors like bone disease, pregnancy, and all. This is not of concern to us. The most important concern is the cardiovascular disease, the metabolic syndrome, the malignancies, the kidney disease because of the immunosuppression, and the recurrence of primary disease. So let us look at each of these particular topics one by one. The first topic that I would like to talk about is post-transplant metabolic syndrome, and it includes a gamut of problems: obesity, cardiovascular disease, post-transplant diabetes, dyslipidemia, and hypertension. And we look at each of these separately and how do we manage this in the long run. We all know that metabolic syndrome is very common post-transplant. The prevalence is around 40 to 60%. There is increased incidence if the patient has a metabolic syndrome, that patient has a more higher incidence of developing cardiovascular disease. And in general, if we look at transplant recipients, when we compare them to the general population, they have twice the more propensity of developing metabolic syndrome as compared to the general population. And we all know that metabolic syndrome is defined by the presence of 3 or more factors: obesity, which we'll look at the BMI or waist circumference, fasting blood sugar being more than 100, blood pressure being more than 130 by 85, triglyceride levels being more than 150, or an HDL level less than 14 males and less than 15 women. The most important problem is obesity. And we all know, we have all seen these post-transplant patients gaining weight, and significantly so in the first year post-transplant. Almost a whopping 30 to 70% of them become obese or overweight as they move on after years after transplantation. And the most important people who develop obesity are those who are elder, as well as those who have a history of obesity before the transplant. 1/3 of patients who are having a normal BMI pre-transplant may become obese post-transplant, and the causes of these are many. First is the steroids that we use post-transplant. This helps the patient to gain weight. Catabolic state is reversed because we have transplanted these patients, as well as there is improved appetite because the chronic disease is gone now, and these patients feel more hungry post-transplant. But we all have seen that all these patients who become eventually obese have an increased 5 and 10-year mortality. And what we can do about this particular problem is that we need to educate these patients, tell them to reduce the calorie intake, tell them to have a daily walk, because the immunosuppressive drugs aren't going to help them. So what we need to do is educate them, ensure that they don't put on unnecessary weight, and ensure that they have a good lifestyle in terms of diet as well as exercise. The next problem, the major problem that we see post-transplant is cardiovascular diseases, and this is the most important cause of morbidity and mortality after liver transplant. Incidence is around 0 to 31% after 6 months of transplant, and we all have seen that the cardiovascular events long-term after transplant are related to the metabolic syndrome. Now, when I say cardiovascular disease, it includes many problems. The most important is coronary artery disease, It can also include peripheral vascular disease, congestive heart failure, strokes, arrhythmias, and myocardial infarction or cardiac arrest. As obesity, similar cardiovascular diseases, more incidence is seen in patients who are elderly and who have a previous history of cardiac disease prior to transplantation. And in a meta-analysis of 12 observational studies, it was found that the 10-year risk of developing cardiovascular events was around 13.6%. Many patients develop diabetes post-transplantation, and the risk factors include post-transplant hyperglycemia, higher age, prior history of diabetes or a family history of diabetes, immunosuppressive drugs like tacrolimus and steroids increase the propensity of developing diabetes post-transplant. Metabolic syndrome doesn't help. Certain genetic polymorphisms like PNPLA3 increase the risk of developing post-transplant diabetes. High fasting blood sugar levels and a high donor liver steatosis are major risk factors as to why a patient develops diabetes post-transplant. If patients develop diabetes and if the sugars are uncontrolled, we have seen that these patients have poor survival. Why? It's because they have increased risk of developing infections, more chances of getting late HATs, that is hepatic artery thrombosis, higher chance of developing cardiovascular events, as well as chronic rejections. The incidence of post-transplant diabetes is around 17 to 18% around for 3 to 4 years post-transplant. So there are many various risk factors as to why a patient develops diabetes post-transplant, apart from the classical factors, which includes a high blood sugar preoperatively, high BMI preoperatively, family history of diabetes, or an African or Hispanic race. There are certain donor-dependent factors too, which includes liver steatosis, increased age, impaired liver function, as well as a deceased donor transplant. There are certain procedure-dependent factors, which includes acute graft rejection, where we use steroids on a higher side in terms of the dosage form, and an increased cold ischemia time of more than 9 hours are risk factors to develop diabetes post-transplant. Certain infections like hepatitis C virus or CMV can also make a patient more prone to develop diabetes. And we all know that immunosuppressive drugs are the major reason why a patient may end up with metabolic syndrome, especially hypertension, diabetes, post-liver transplant. There are certain emerging factors which are probably playing a role in patients developing post-transplant diabetes mellitus, but these have still not yet been proven in literature. So how do we really manage these patients who develop post-transplant diabetes? How do we diagnose them, first of all? So if any patient presents to you in your OPD post-liver transplantation, in terms of how do we evaluate them, we tell them to do every 3 months for the first year and then annually a fasting plasma glucose. We also tell them to do an HbA1c level, that is the glycosylated hemoglobin level, every 3 months. If these patients are having diabetes preoperatively, or if we have a patient who has a new onset diabetes post-transplant, we must look at the complications of diabetes, which includes annual screening for retinopathy, screening for microalbuminuria, as well as looking at the lipid profiles. For all patients who develop diabetes post-transplant, we need to have a dietitian as well as good dietary advice in terms of reduction in the amount of sugar, free sugar that these patients eat, and lifestyle modification in terms of exercise and weight loss. We also must treat the other factors that are associated with diabetes, which includes hypertension and dyslipidemia. And the drugs that we use for diabetes are oral hypoglycemic agents. And if the sugars are not well controlled with oral hypoglycemic agents, we can put them on insulin too, or a combination of both. The second problem, apart from diabetes, is dyslipidemia. And the causes of dyslipidemia post-transplant include higher age, certain genetic predispositions, excessive intake of carbohydrates, cholesterol, saturated fats. Now, these patients post-transplant are very happy. They now can eat all foods which are rich in, which are having a lot of salt, which is rich in calories. The catabolic state has been reversed. Now they're happy. They are on steroids. So the appetite is high, and these patients can eventually take in more calories as compared to a normal individual, which makes them gain weight. Certain drugs that we use post-transplant, if the patient is having hypertension, if the patient is having a higher heart rate, like diuretics and beta blockers, also predispose patients to develop dyslipidemia. And again, as we spoke about diabetes, these immunosuppressive drugs, all of them predominantly worsen the lipid profile. Now, how do they really do this? Immunosuppressive drugs can cause insulin resistance, which leads to a lot of release of which are free fatty acids from the adipose tissue. And these free fatty acids are a main substrate of VLDL formation and eventually LDL formation. Certain drugs like mTOR inhibitors, sirolimus can alter insulin signaling, causing insulin resistance. Steroids increase the activity of the rate-limiting enzyme 3-hydroxy-3-methyl-butyryl coenzyme A, which is a step in cholesterol synthesis pathway and can cause increased synthesis of cholesterol. Cyclosporin, which is a calcineurin inhibitor, interferes with the binding of LDL to the LDL receptor and can cause a rise in LDL levels, as well as can cause LDL receptor downregulation. And this is predominantly why these drugs cause dyslipidemia. So what do we do if a patient has dyslipidemia post-transplantation? How do we manage these patients? So if you have a patient who comes to you post-transplantation, you do a lipid profile, you screen them every 3 months, initially, then every 6 months, or annual screening. If these patients do not have any dyslipidemia prior to transplant, if these patients' LDL level is more than 100, we tell them to do therapeutic lifestyle modification as well as dietary changes. Add statins, for example, rosuvastatin, 10 milligrams or 20 milligrams, depending upon the level. And if still the LDL level is not controlled, maybe adding ezetimibe helps. If these patients have isolated high triglyceride levels, then treating them with fibric acid derivatives and fish oil at the dose of 1 gram twice a day to 4 grams daily benefits them. But if these patients still do not improve, still the levels are still high, the LDL levels are high, cholesterol levels are high, triglyceride levels are high, then we may have to alter the immunosuppression too. If these patients are on cyclosporin, which makes the patient more prone to develop dyslipidemia, convert the cyclosporin to tacrolimus. In general, reduce the CNIs, both cyclosporin and tacrolimus. We may add on mycophenolate mofetil. And if these patients are on mTOR inhibitors like sirolimus and everolimus, maybe discontinuing them helps in cases of refractory hyperlipidemia. Then comes hypertension. We have spoken about this obesity, we have spoken about diabetes, we have spoken about dyslipidemia. The other problem with metabolic syndrome, the other factor that is inclusive in metabolic syndrome is hypertension. And 3 drugs that we use post-transplantation make a patient more prone to develop hypertension, which includes calcineurin inhibitors, corticosteroids, and mTOR inhibitors like sirolimus. Now, how does this really happen? Calcineurin inhibitors cause widespread arterial vasoconstriction that increases the SVR. It also causes renal vasoconstriction, which promotes sodium reabsorption and expansion of volume. And this is the reason why these patients develop hypertension. Now, the incidence is a whopping 50% post-transplantation, especially at 5 to 10 years post-transplant. Almost 50% of patients may end up having high blood pressures. And how do we treat these patients? If they're having high blood pressure, the target of blood pressure should be 130 by 80 milligrams of mercury. The best drug to use for these patients is amlodipine or nifedipine. If these patients are having associated chronic kidney disease, if their patients are having diabetes, if there's proteinuria, if there's heart failure, we may add on an ACE inhibitor or an ARB, that is an angiotensin receptor blocker. Or if these patients post-transplantation also have some amount of low-grade coronary artery disease, then beta blockers would be the ideal choice of drug for treating the high blood pressure in patients who are specifically having chronic coronary artery disease post-transplant. So this is in general the summary of what we spoke till now. If the patient is obese, educate them, give them good dietary advice, tell them to exercise and avoid steroids. If the patient is diabetic or hypertensive, tell them to again do lifestyle modification, use insulin, use the oral hypoglycemic agents, use your amlodipine, use ACE inhibitors, use beta blockers. If still not working, try and reduce the CNI levels. Try and push these patients from lesser CNI to more of mycophenolate mofetil, which might help in diabetes and hypertension. If these patients become dyslipidemic, again, lifestyle modifications, statins, high triglyceride levels, fibric acid derivatives, try and reduce the CNIs, try and reduce the mTOR inhibitors. Again, mycophenolate mofetil is a better drug to use if the patients are having refractory dyslipidemia. And in general, about immunosuppression, the lesser the immunosuppression, the better. We all know, as the previous speaker has spoken, that liver is an immune tolerant organ. So if these patients are having normal liver function tests post 1, 2, 3 years post transplantation, we don't chase the TAC levels. What we do is just look at the LFT, and if the LFT is doing well, we try and reduce the immunosuppression eventually to the least minimal dose as possible. We move on from post-transplant metabolic syndrome to chronic kidney disease. Now, in this particular topic, I'll talk about what causes chronic kidney disease, how do we identify it early, and how do we manage these patients with chronic kidney disease. As we know that the risk of developing end-stage renal disease is almost 25%, 5 to 25% during the first 10 years post-transplantation. And the cumulative incidence of somebody developing a chronic kidney disease post-transplantation at around 5 years is 18%. Why does this happen? Is because these patients use these immunosuppressive drugs, especially the calcineurin inhibitors, which is the backbone of treatment for of immunosuppressive therapy post-transplant. Some of these patients might have diabetes, hypertension, obesity pre-transplant, which predisposes them to get more kidney disease. Sometimes these patients can have HCV infection prior to transplantation. Chronic HCV infection predisposes to CKDs, as well as having AKI and perioperative acute kidney injury or pre-transplant AKI HRS can predispose these patients to develop chronic kidney disease in the long run. If any patient develops chronic kidney disease post-transplant, there is a higher risk of death, almost a 4.48% higher chance that these patients may eventually have a mortality post-transplantation as compared to the general population. We all have seen that the decline in the glomerular filtration rate after transplant occurs in predominantly two phases. The first phase is because of the immunosuppressive drugs, where there is a steep decline in the GFR, and then eventually there is a gradual decline in the GFR, which we see after 4 months post-transplantation. And there are various factors that can cause person post-transplant to develop renal dysfunction. There are certain pre-transplant factors like diabetes, hepatitis C, or drugs. Hepatorenal syndrome, or AKI-HRS, what we call nowadays, are pre-transplant risk factors for somebody who develops post-transplant renal dysfunction. Certain peri-transplant factors like hypotension, acute loss of blood requiring a lot of blood transfusions, and certain medications that we use in peri-transplantation can predispose a patient to develop post-transplant renal dysfunction. And then we all know that these immunosuppressive drugs post-transplantation, having all these metabolic syndrome, factors like diabetes, hypertension can all affect the kidney in the post-transplant scenario. Now, how do these immunosuppressive drugs really cause nephrotoxicity? It causes nephrotoxicity predominantly in two ways. First is an acute component where there is thrombotic microangiopathy and afferent arteriolar vasoconstriction. Because of this, there is nephrotoxicity, but in an acute phase, this is a reversible process. So it is a dose related but a reversible process. So if we see that the creatinine is going up or the GFR is reducing post liver transplant, immediately post liver transplant, if the TAC level is high, what we do is withhold the doses of tacrolimus for a few doses and then re-add them at a lower level, prevent this acute injury. Acute injury is reversible, but the problem is the chronic CNI exposure, that is the chronic exposure to tacrolimus and cyclosporin, that affects the renal vessels, causing arterial hyalinosis, affects the renal tubules, affects the interstitium, affects even the glomeruli, and all these together can cause chronic renal dysfunction in a patient post liver transplantation. So this is a very good diagram that shows the mechanisms how renal dysfunction happens post-transplant. In the acute phase, you can see thrombotic microangiopathy as well as afferent arterial vasoconstriction are the two major reasons why there is acute CNI nephrotoxicity. And in the long run, these CNIs affect all levels of the kidney, may it be the glomeruli, may it be the tubular interstitium, may it be the later part of the renal tubule, and all this eventually predisposes a patient to develop chronic kidney disease post-transplantation. So how do we recognize these problems early on? Creatinine is not a great marker. It is a late marker. What we use predominantly to find patients who are developing renal dysfunction is the MDRD formula. Proteinuria, by doing a spot protein examination, is yes, it can be used as a marker, but sometimes in patients with advanced CKD, if they are on CNIs, the CNIs have an anti-proteinuric effect and they may not present at all with proteinuria. How do we treat patients with chronic kidney disease? We all know that these patients can have high blood pressures, and what we need to do in these patients is to block the renin-angiotensin-aldosterone system. How do we do this? Is by trying to reduce the immunosuppression level, immunosuppressive drugs, which are the CNIs, which cause CKD, and try and get renal sparing maintenance protocols into place by changing the CNIs to everolimus and adding on mycophenolate mofetil. Now, what problem we all face post-transplantation is that we recognize all these patients predominantly very much late. So what do we need to do is recognize them early and get the CNIs as early as possible out of the immunosuppressive protocol and probably shift them over to mTOR inhibitors. So renal dysfunction is definitely an increasing problem post-transplantation. We have a substantial burden of post-transplant renal dysfunction, which have got a very high short-term mortality, especially in those patients who have pre-transplant chronic kidney disease. We all know that the MELD allocation system has creatinine as a part of it, and a higher MELD scores and sometimes a high creatinine can push up the MELD score, and this selects the patients who have more renal dysfunction into getting a transplantation. And as these patients survive longer, they have more and more exposure to CNIs, which can eventually cause a lot of accumulation of, which can cause a lot of renal toxicity. So how does changing from tacrolimus to an mTOR inhibitor, which is everolimus, help? And this is a fantastic diagram that shows how it helps. So if you change from tacrolimus, that is, you withdraw the CNI early, or if you use a low dose TAC and add on an everolimus, or maybe change completely to everolimus, it improves the eGFR. Especially it does so initially in the early phase. It really definitely improves the eGFR, and even in the long run, almost 2 years post transplantation, we have seen that patients who get shifted from tacrolimus to mTOR inhibitor, especially those who have chronic kidney disease or those who have an early sign of renal dysfunction, do far better in terms of how their eGFR behaves when you have an early shift to everolimus as compared to them continuing the tacrolimus. Now, we must be careful that everolimus, shifting very early to everolimus, may interfere with wound healing. So the ideal time to shift to everolimus, if we see renal dysfunction, is around 4 to 6 weeks post-transplantation. We move on from the kidney disease to de novo malignancy. We all know that patients who receive a liver transplantation or any transplant per se have a higher incidence of developing a de novo malignancy. And if they have an HCC, which is beyond Milan criteria, there is a very high risk of they developing a recurrent HCC post-transplantation. The incidence of de novo malignancy is higher as compared to the general population, and it is around 3 to 5% in the first 3 years to around 11 to 20% around 10 years post-transplantation. And the risk factors include male sex, alcohol, sun exposure, cigarette smoking, PSC, as well as the Epstein-Barr virus. And we need to have good surveillance protocols in place to identify these patients who might develop a malignancy post-transplantation. And this is a relative risk table which shows relative risk of patients who develop de novo malignancy post-transplantation. If we look at all the registries, again, it shows a very high incidence of post-transplant lymphoproliferative disorders that happens in patients who have any transplantation and who survive for long. If any patient develops a solid organ malignancy, their survival is poor unless diagnosed early. Especially if these patients get a hematologic malignancy, their survival is very dismal. It is almost a probability of death of around 44% at 1 year to 60% at 5 years if not identified early. And hence, we should have an intensified surveillance protocol to diagnose this early. How do we do this? Look at an annual skin examination, especially of those patients who have who belong to the American as well as the European origin. They have a more chance of developing skin cancers. If the reason for a transplant was PSC, or if the patient had a previous history of ulcerative colitis, then you should do an annual colonoscopy to look at colorectal cancers. Do an annual chest X-ray or a yearly CT scan, especially patients are having cough, if they're actively smoking, to look for lung cancers. do a good ENT examination by specialists, especially patients who are having tobacco or who are smoking or are consuming alcohol post-transplantation, as well as in female recipients, it goes as what we do in the routine practice. We do an annual pelvic examination as well as an annual mammography starting at the age of 45 for female recipients and a PSA at the age of 50 for male recipients. An ultrasound examination is a good test to find out if these patients are developing renal carcinomas eventually. So this is how we do surveillance post-transplantation, especially 2, 3, 4 years after transplantation when the chances of developing malignancies increase. We all know that if a patient has been transplanted for an HCC, if the patient is within the Milan criteria, the chance of recurrence at 4 to 5 is around 10%. But if the patient is outside the Milan criteria, it's very high. And hence, that's why the Milan criteria came into place. Can be as high as 40 to 60% of developing a recurrent HCC if the patient is outside Milan criteria. And how do we reduce the incidence of this recurrence is by adding on an everolimus or adding on a sirolimus early on post-transplantation, like what we do for the kidney, for patients who develop kidney or renal dysfunction post-transplantation. If you have a patient who has an HCC and who has underwent a transplantation, how do we follow up these patients? Do an abdominal or chest CT every 6 months for the first 3 years post-transplantation and serially follow up their alpha-fetoprotein, especially if they have a high alpha-fetoprotein level prior to transplantation, then we must serially follow this up. And any rise in AFP should open up your ears into getting a tract physics CT abdominal or MRI with contrast for patients post-liver transplantation to pick up the post-transplant recurrence of HCC early. Few important points about bone health and rejection pregnancy. Bone health, as we all know, in the first 4 months post-transplant, there is accelerated bone loss because of these immunosuppressive drugs. And eventually, the bone health improves after the first 4 months of transplant. So these patients have a high susceptibility of having fractures of the trabecular bone. And if such a thing, if you feel that these patients are having poor bone health, try and get the glucocorticoids to be discontinued as early as possible. Do their BMD screening in the first 5 years, especially if these patients are osteopenic. Put them on calcium supplements, put them on vitamin D supplements, ensure that the vitamin D level is at least 30 nanograms per milliliter. And if these patients are having a poor T-score on the BMD, then put them on bisphosphonates like alendronate 70 milligrams weekly. Or if the patient is unable to tolerate alendronate, then intravenous zoledronic acid helps in improving the bone health post-transplantation. We have seen rejection. Rejection is a main problem, especially in the first year post-transplantation. If you have a mild rejection, the best way to diagnose a rejection is by doing a liver biopsy. But sometimes clinically, we just look at the liver enzymes. If we feel that the liver enzymes are going up and there is no other reason why it should go up, and we feel that the TAC levels are slightly low, we just try and push up the TAC levels and increase the maintenance levels of the immunosuppression. But if these patients are having predominantly significant derangement in the liver function test post-transplantation, we must biopsy these patients. And biopsy is most important in finding if these patients are having a rejection episode post-transplantation. And if they have a rejection episode post-transplantation, treating them with pulse corticosteroids in the dose of 500 milligram per day for 3 days and increasing the baseline immunosuppression helps. 70% of them would respond, but eventually a group of these patients may develop again recurrent episodes of acute rejection, and sometimes 5% of them develop chronic rejection, which we call as ductopenic rejection. In patients with ductopenic rejection, we have classically in the histopathology an early stage cellular infiltrate, progressive loss of bile ducts, and foamy macrophages. If you find these particular factors on the histopathology of the liver biopsy, then these patients are more prone to have chronic or ductopenic rejection. And we have seen that in these patients, if you switch over from a CNI to an mTOR inhibitor, we can salvage at least 50% of these particular patients who develop a ductopenic rejection. Now, the predominant symptoms of these patients, they predominantly present with derangement of LFTs and a cholestatic picture, where you have a high alkaline phosphatase and GGTP and a progressive rise in bilirubin. You may change over the immunosuppression, but once the patient develops chronic rejection, it's bad news. Though the incidence is very less, but these patients may eventually land up with a retransplantation. Now, there are many ladies who undergo liver transplantation, and how do we really tell them how to manage the pregnancy? We all must know that there are certain drugs which are a strict no, because these drugs can cause birth defects. Mycophenolate mofetil and azathioprine is strictly prohibited. You should not use these drugs in patients who want to plan a pregnancy. The safest drugs in pregnancy are tacrolimus and steroids. We all know that patients who have post-transplant who become pregnant, we all know that cirrhosis, if the patient is having cirrhosis, the patient's fertility is quite less, and these patients hardly become pregnant. But once they receive a transplantation, the fertility comes back. In fact, the ovulation may come back in the first month post-transplantation. But these patients, as compared to the general population, have a higher incidence of preterm births, preeclampsia, more chance of getting a cesarean section, and more incidence of spontaneous abortions. So we must tell these patients to plan their pregnancy and avoid unnecessary pregnancies, especially when once the liver graft function stabilizes. That would be a good time to get pregnant. Especially 1 year post transplantation is a good time to get pregnant, and not before that. So we tell these patients to use contraception, and the best contraception for these patients are condoms and intrauterine contraceptive devices. These two would be the most important. We all know their problems, but still these two would be the most important advice that we can give these patients for contraception post-transplantation. Immunization, we should avoid live vaccines in all transplant patients, but we as a protocol in our institution, we pre-transplantation we immunize these patients with an influenza vaccine, with a pneumococcal vaccine, as well as with the hepatitis B vaccine. But if these patients are long-term in your follow-up, then you must give them the annual flu vaccine, and every 5 years the pneumococcal vaccine post-transplantation. But do not give these patients live vaccines, because it is not recommended in patients who are on immunosuppressive drugs to get live vaccines. As physicians or as surgeons, we must know about the drug-drug interactions of certain immunosuppressive drugs. Commonly, we prescribe certain drugs, certain antibiotics post-transplantation as a routine. We must know that fluoroquinolones as well as macrolide antibiotics like clarithromycin, azithromycin, and erythromycin increase the levels of CNIs post-transplantation. Certain rifamycins like rifampicin or rifabutin decrease the levels of CNI and mTOR inhibitors post-transplant. Linezolid, ganciclovir, and valganciclovir can cause increased myelosuppression. Certain antifungals like ketoconazole, voriconazole, posaconazole can cause increased levels of CNIs and mTOR inhibitors. Certain blood pressure lowering medications like calcium blockers, calcium channel blockers like verapamil, diltiazem, amiodarone, cimetidine, protease inhibitors like what we use for HIV patients, danazole, increase the levels of CNIs as well as mTOR inhibitors, and anti-epileptic drugs like phenytoin, phenobarbital, and carbamazepine reduce the levels of CNIs and mTOR inhibitors post-transplantation. And we must keep all these drug interactions in mind. These are not many, so we can keep these in mind, especially when we prescribe patients who have got a liver transplantation certain medications, if at all it's required. You may take a snapshot of this. Is a fantastic slide. We all know that immunosuppressive drugs cause a lot of problems. We have seen about these problems in the previous few slides, so I'll not go into details again. But this is a very good overall view of the adverse drug reaction profile of immunosuppressive drugs: corticosteroids, bone diseases, diabetes, hypertension. Calcineurin inhibitors like tacrolimus and your cyclosporin cause a lot of CKD or a kidney injury post-transplantation hypertension. mTOR inhibitors cause proteinuria, increase cholesterol levels, hypertension, and mycophenol and mofetil cause gastrointestinal and bone marrow suppression. And this is the overall overview of the adverse drug reactions of immunosuppressive drugs. We all know that if a patient is transplanted for certain disease, there can be recurrence of disease post-transplantation. And how do we deal with these? So if the patient is having hepatitis B virus, if the patient is having acute liver failure because of hepatitis B virus, and we transplant these patients for acute liver failure, if the viral load is high, we may use a immunoglobulin for these patients, the hepatitis B immunoglobulin. We all know that these nucleoside analogs are very good drugs. They really suppress the HBV DNA levels pre as well as post transplantation. And these should be given lifelong to patients who receive a transplant for hepatitis B virus. Nowadays, in routine clinical practice, we are seeing lesser and lesser patients who get transplanted for acute viral hepatitis B in our part of the world. So the use of HBIG is going down eventually. We all know that patients post-transplantation become obese, and especially those patients who have a pre-transplant obesity are more at a risk of developing post-transplant recurrent NAFLD. Sometimes patients gain weight post-transplant and may develop a de novo NAFLD. And if these patients develop so, we all have seen that these patients can develop an accelerated fibrosis in the new grafted liver. Metabolic syndrome is present in significant number of these recipients, and almost a prevalence of 24 to 100%. If you see a patient 5 years post-transplantation, you do a fibroscan, these patients, 50 to 70% of them would have fat in their liver. HCV in the sofosbuvir, velpatasvir era, HCV is almost like it's almost gone in terms of good viral suppression. The SVR rates are almost 90 to 95%, especially in the genotype 1, 2, and 4. And sometimes it can happen that a patient has hepatitis C virus and develops an acute liver failure. For these patients, we must keep in mind that after transplantation, there is a lot of interaction of the immunosuppressive drugs with the directly acting antivirus like sofosbuvir and velpatasvir. Those interactions you may keep in mind. But if you have time, it's always better treat the patients for hepatitis C virus first, and then eventually make them have a transplantation if their liver is badly decompensated. Primary biliary cholangitis, the incidence of post-transplant developing again the same disease around 4 to 33%. We know that putting these patients on a low-dose corticosteroids or cyclosporin is associated with less recurrence. Diagnosis is only liver histology. These patients post-transplant, even if they develop again a recurrent PBC, may show normal liver tests, may not even show an AMA positivity. But liver histopathology is the most important way by which we diagnose recurrent primary biliary cholangitis. And the treatment of recurrent PBC is usually ursodeoxycholic acid, which causes an improvement in the liver function tests. But long-term data, we are not really sure whether it helps in patient or graft survival. The problem is PSC, which has got a very high incidence of recurrence, almost 40% at 10 years. So all these patients who have a PSC to start with, who undergo transplantation, have an HJ, and we all know that in the rule loop, there is an increased incidence of recurrent cholangitis. If at all we keep some native bile duct back, there is a very high risk that these patients may develop cholangiocarcinoma, and hence we do an HJ for as a preemptive step in patients who have PSC who undergo liver transplantation. Ulcerative colitis associated with PSC, and we all know that colitis may improve or deteriorate post-transplantation, and we must screen these patients with an annual colonoscopy to pick up these colorectal cancers early, especially if these patients are having ulcerative colitis. And we all know that 90% of patients with PSC have an associated ulcerative colitis, predominantly as well as Crohn's disease. Autoimmune hepatitis can come back again, or some patients may have a de novo autoimmune hepatitis, and the way to diagnose this is by doing a liver biopsy. And if at all a patient develops a post-transplantation de novo or recurrent autoimmune hepatitis, their long-term survival is not that bad. It's almost more than 70% at 5 years. And if patients who have an autoimmune hepatitis and undergo liver transplantation, we do maintain them on a very low dose of corticosteroids to prevent recurrence of autoimmune hepatitis. So if we just look at management protocols, autoimmune hepatitis, low-dose steroids, azathioprine, addition of mycophenolate activity, and increasing the levels of immunosuppressive drugs helps in preventing recurrence. For primary biliary cholangitis, it is ADCA, that is ursodeoxycholic acid. And for primary sclerosing cholangitis, it is antibiotics for cholangitis and treating the dominant stricture with an endoscopic intervention. Relapse rate, recidivism is very high in patients who develop who undergo transplantation for alcohol abuse, and we see a relapse rate of almost 16 to 34% post transplantation, and which is kind of very disheartening, because these patients eventually receive a transplant for alcohol and they go back to their drinking habits. There are certain predictors for relapse. We can see it in this particular slides. I'm not going to details of this, but counseling these patients, making them understand, and ensuring that these patients do not go back to alcohol consumption by drilling it into their heads every time they come to the OPD for follow-up. When they're feeling good, they go back to drinking, they go back to the poor lifestyle as well as harmful drinking, and we must prevent this by counseling them on a day-to-day, on a routine basis. Certain good health instructions, frequent hand washing is very important. If certain of your transplant patients are doing outside work, for example, they are farmers, if they're having exposure to soil, make them wear protective dressing like shoes, socks, long sleeve t-shirts, long pants. Especially in the first year post-transplantation, there is maximal immunosuppression, so they should try and avoid crowds, try and wear a mask. If they're working in certain animal care settings, gardening, landscaping, farming, we should use appropriate strategies for prevention of high-risk exposures. If we should avoid these patients from drinking direct water from lakes and rivers, boil the water as much as possible. Do not use unpasteurized milk products, raw, undercooked eggs and meats, and avoid high-risk pets, especially in the first year post-transplantation. And these are the general instructions that you would give these patients post-transplant. So to conclude, in terms of long-term survival after transplant, it is mainly affected by cardiovascular disease, hypertension, diabetes, de novo malignancies, chronic kidney disease, and recurrence of primary disease. The LT recipients are increasingly more than 65 years of age. They have a more propensity of developing metabolic syndrome as well as obesity. We must be aware about how these immunosuppressive drugs interact with each other and the common issues post-transplantation, the routine follow-up, screen them regularly. Recurrent disease is very common, but generally only leads to graft loss in malignancy and primary sclerosing cholangitis. And many of the risk factors to these diseases are modifiable. It is important to identify patients at risk and manage accordingly. Thank you so much. And this is an overview of what we have done over the last 5 years at Apollo Hospitals, Navi Mumbai. Then around 226 liver transplants. At Medanta, we have done so many, but at Apollo, we have done in the last 5 years a commendable job, especially during the COVID time, of doing around 226 liver transplantations. And we have just transplanted 2 more in the last week. Thank you so much for patient listening. If you have time, can I just cover some couple of slides only, immediate post-op care? Or
Please,
I think if we are
go ahead.
right. Okay, so only a couple of slides because predominantly the immediate post-op care is predominantly the job of liver intensivists as well as the hepatobiliary surgeons. The most problems come out of the surgery itself, and a hepatologist has limited role in immediate post-op care management of these patients. Uh, Cardiovascular problems are very common. There is a lot of hypotension during reperfusion, which may require inotropes. If the patient is not maintaining his blood pressure, rule out any unrecognized cardiac dysfunction, do a right heart dysfunction. If there is elevated pulmonary artery pressures, maybe putting these patients on prostaglandin E2 helps. Immediate post-transplant, there are certain respiratory issues. Giving a lot of fluid to them can cause pulmonary edema. Giving a lot of blood products can cause TRALI. ARDS is very common, especially in acute liver failure patients. Sometimes, if the patients are intubated for a long period of time, they may develop infections like pneumonia, and we must pick this up very early. These patients, predominantly who get a transplant, may have a pre-transplant HRS and AKI. And for these patients, as my previous speaker spoke about, renoprotective strategies like putting in a basiliximab early on at day 0 and day 4 may help in putting on the tacrolimus at a later stage post-transplantation. So renoprotective immunosuppressive strategies help in patients who have renal dysfunction pre-transplant. But if these patients are still oliguric, anuric post-transplantation, despite good volume repletion, despite maintaining an optimal perfusion pressure, we should consider an early renal replacement therapy. And this at least supports the kidneys and helps these patients come out at a faster as well as a better prognosis when the patients develop a renal dysfunction. In terms of the gastrointestinal system, we must ensure that these patients have a peptic ulcer disease prophylaxis. If these patients have an HJ, we may delay the feeding by a few days, but early enteral feeds always helps. We must look at pancreatitis because this is a problem in patients who are especially having an acute liver failure, especially those who have an acute liver failure because of paracetamol overdose. In the neurological symptoms, in the neurological system, patients with acute liver failure who get transplanted have high raised intracranial pressure, and 2% normal saline is used in this particular group of patients. Sometimes these patients bleed inside the brain because they're coagulopathic, because there is thrombocytopenia, and if they have a focal neurological deficit post-transplantation, we must pick it up early by doing an immediate CT scan. An overzealous correction of sodium can cause central pontine myelinolysis, and the most important way we diagnose this is that these patients have quadriplegia and brainstem signs. We all know that calcineurin inhibitors can cause a lot of neurological issues and can have seizures. There is an entity called as posterior reversible encephalopathy syndrome, PRES, which we must recognize early. Immunosuppression related seizures or neurological dysfunction. If these patients, we feel that these patients have got this particular problem because of immunosuppressive drugs, withdrawing that particular drug and changing over quickly to cyclosporin at times helps, especially when tacrolimus is the offending agent. And if these patients have a post-transplantation hematological issues in terms of bleeding, the best way to correct this is by using a thromboelastogram, and that really helps us in giving blood products intraoperatively as well as post-operatively when these patients are bleeding and require any blood product transfusion or any other particular way in which we can prevent increased bleeding tendencies. We should give these patients good antimicrobial prophylaxis, antifungal prophylaxis. We all know that fluconazole can push up the TAC levels a bit. So use this fluconazole to advantage, especially if these patients are maintaining a low TAC level post-transplantation. We must recognize two things very early post-transplantation, that is a primary non-function and a primary graft dysfunction. And three things help us in doing this is the bile output, is the ALT level and the prothrombin activity. And we have got various scores to look at this particular thing. Small for size syndrome, especially in patients who have a GRWR of less than 0.8, and we transplant these particular patients, they develop ascites and a lot of drain output post-transplantation. So we must recognize SFSS early and treat these patients accordingly. Acute cellular rejection is again very common, is predominantly common in patients who are having PSC or AIH post pre-liver transplantation. We must recognize this early, increase immunosuppressive drugs, and biopsy these patients. That's the best way to deal with this, and give them a good amount of methylprednisolone in terms of pulse doses to get the acute cellular rejection treated. We must know that acute cellular rejection is a treatable condition, and the earlier recognition and treatment really helps in improving outcomes. Patients post-transplantation are immunosuppressed. They may have a high chance of developing viral infections. So identifying these viral infections early is very important. May it be CMV, EBV, HSV, or a recurrent hepatitis B, hepatitis C virus infection. If the viral load increases when we immunosuppress these patients, we must pick this disease early. Hepatic artery thrombosis is a very bad omen post-transplantation. Again, doing a CT scan, especially with the contrast, helps in picking up these patients early. A Doppler screening, and if the Doppler is haywire, then getting these patients scanned very early up and treating with them with ideally thrombectomy, or if at all it doesn't work, then maybe these patients may end up landing with a retransplantation also. Post-operative bleeding, again, a surgical issue. Tech-based correction helps. Sometimes we may have to reopen these patients and treat it accordingly. Some patients have a recurrent encephalopathy, or encephalopathy keeps on going on post-transplantation, and weaning them off from a ventilator becomes difficult, especially those patients who have a hepatopulmonary syndrome. They don't maintain the oxygen levels, and so having a good support from the ICU in terms of intensive care helps in this particular group of patients. And identifying sepsis. Sepsis really is a problem, especially in our part of the world where there's a lot of antimicrobial misuse or unnecessary use of antibiotics, and this causes a lot of resistance in the bacterial flora that we have, and predisposes patients in having sepsis, especially because these patients are immunosuppressed. And identifying sepsis early, knowing the subtle signs of sepsis, increasing heart rate, slightly reducing urine output, slightly falling platelet count, is a telltale warning sign. Identifying this early and being preemptive, treating the sepsis before it sets in completely is the key to managing these patients post-transplant. Thank you so much for your patient listening. It was slightly extensive. I really apologize for that, and sorry for shooting my time by almost 25 minutes. And thank you so much once again for listening to this. Thank you so much.
Thank you very much, Dr. Amey. Very informative presentation, very detailed, very thorough, and very clear. We thank you very much. And on behalf of the Society of Uganda Gastrointestinal and Endoscopic Surgeon, we thank you for your time, and we know you are ahead from us by, I think, 2.5 hours. So you should be resting, but you volunteered your time. So we appreciate. So,
Thank you so much.
Dr. Nagadia, do you have any questions on the chat or any questions? So we have two groups of audiences. the ones online, and then we have a team that is gathered here at the city center, Kololo, where we are sharing, where we shall share